Welcome to Board Pearls. This is episode 1 of 3 of the Acute Pancreatitis chapter in the Pancreatic and Biliary Disease module. This episode is the first hours: how you diagnose it, how you pin the cause, how you stratify severity, and the fluid decision that changed in the last few years. Acute pancreatitis is one mechanism with many triggers, and the first hour's teaching follows the mechanism. The Acinar cell prematurely activates trypsinogen to trypsin inside itself. Trypsin then cleaves the rest of the digestive enzyme pool, and the gland begins to digest itself. The triggering insult differs by cause, but the convergent step is the same. Cytosolic calcium rises and stays up. The enzyme granules co-localize with lysosomes. A lysosomal enzyme cleaves trypsinogen, and the cascade starts. That single point of convergence is why such different triggers produce the same syndrome. Each trigger pushes on calcium a different way. An obstructing gallstone at the ampulla raises ductal pressure and forces bile or pancreatic juice back into the acinar cell. Alcohol sensitizes the cell and impairs enzyme packaging. High triglycerides deliver free fatty acids that disrupt the membrane and dysregulate calcium. High calcium drives the sustained elevation that cleaves trypsinogen on its own. Once trypsin is generated inside the cell, an inflammatory transcription program fires. The cytokines that follow drive the systemic inflammatory response that defines clinical pancreatitis. Capillary leak third spaces fluid into the retroperitoneum and gut wall and lung. Intravascular volume falls. The pancreatic microcirculation collapses, and edematous pancreatitis becomes necrotizing pancreatitis. That sequence sets up the specific findings the boards test. Hypocalcemia in severe disease reflects free fatty acids saponifying with calcium in fat necrosis, forming calcium soaps in the retroperitoneum. The Cullen sign at the umbilicus and the Gray-Turner sign at the flanks reflect retroperitoneal hemorrhage from enzymatic erosion of vessels, and their presence implies severe disease with poor prognosis. And the reason necrosis takes 72 to 96 hours to declare on contrast CT is the same mechanism. The parenchyma has to lose perfusion long enough for non-enhancement to be visible, so a scan at 12 hours can show enhancing gland that 2 days later is completely non-perfused, which is exactly why the reflex to get a first-day CT misclassifies severity and is the wrong habit. The patient comes in with sudden severe epigastric pain radiating to the back in about half, steady rather than colicky, peaking within minutes to hours, and worsening with eating because food stimulates the pancreas, with nausea, vomiting, epigastric tenderness, and a quiet abdomen from ileus, and in severe disease with hemodynamic instability from third spacing, or respiratory failure from ARDS. The enzyme test is lipase, not amylase, for 2 reasons. It rises within 4 to 8 hours and stays up for 8 to 14 days, giving a wider window, and it's pancreas-specific, whereas amylase falls within a few days and is raised by parotitis, tubo-ovarian disease, macroamylasemia, and renal failure. The revised Atlanta classification then diagnoses on a 2 of 3 rule: characteristic upper abdominal pain, lipase or amylase over 3 times the upper limit of normal, or characteristic cross-sectional imaging. It's 2 of 3 precisely because each element has a known failure mode, pain alone is nonspecific, enzyme elevation has many causes, and imaging alone doesn't establish a clinical syndrome, so any 2 together get you there. Imaging is reserved for diagnostic uncertainty, failure to improve at 48 to 72 hours, or suspected complications, and routine early CT is avoided because necrosis takes those 3 to 4 days to demarcate, so you wait it out rather than scan into a moving target. There's one favorite trap inside the enzyme rule. Severe hypertriglyceridemia interferes with the lipase and amylase assays and can produce falsely normal values, so the serum looks lipemic and the sodium reads falsely low because lipid displaces the aqueous phase, the pseudohyponatremia finding, and yet the clinical and radiographic picture is still diagnostic even when the enzymes look normal. The corollary that travels with it is that the height of the enzyme does not track severity because the lipase number reflects Acinar release kinetics, not the inflammatory cascade and third spacing that drive organ failure. So a lipase of 8,000 does not mark a sicker patient than a lipase of 3,000. Severity in the Atlanta framework grades on organ failure. Mild disease, the majority of cases, has no organ failure and no complication. Moderately severe disease has transient organ failure under 48 hours, or a local or systemic complication. Severe disease requires persistent organ failure beyond 48 hours, defined as a modified Marshall score of 2 or more in the renal, pulmonary, or cardiovascular system. The key point is that early severity is provisional, because moderately severe and severe disease only declare over the first 2 to 3 days, and most patients who eventually die look mild on day 1, which is what the discipline of the first 72 hours is built around. The cause gets worked up during the index admission, not deferred to clinic, because the trigger reshapes the whole admission. Gallstones and alcohol together account for most cases. Gallstones the larger share, with the remainder from high triglycerides, drugs, high calcium, post-procedure, autoimmune, anatomic, hereditary, and a small idiopathic residual. A right upper quadrant ultrasound is mandatory in everyone at presentation, because a positive study means same admission cholecystectomy, which reshapes the admission. An ALT over 3 times normal, roughly above 150, carries a high positive predictive value for gallstone pancreatitis even when the ultrasound is unrevealing. And since transabdominal ultrasound is poor at seeing distal bile duct stones, MRCP or endoscopic ultrasound is the next step when obstruction or cholangitis is suspected, despite a clean scan. Alcohol-induced disease takes more than 5 years of heavy use, typically over 50 grams a day, and fewer than 1 in 20 heavy drinkers ever develop it. Because the mechanism is alcohol sensitization layered on a host susceptibility that smoking and certain gene variants modify, which is why most heavy drinkers escape and a subset don't. High triglycerides is the diagnosis when they exceed 1,000, with significant risk concentrated above 2,000, and the bedside clues are lipemic serum, pseudohyponatremia, and falsely normal enzymes from assay interference, with causes including uncontrolled diabetes, familial chylomicronemia, alcohol, and drugs like estrogens, thiazides, and tamoxifen. Acute treatment is fasting for at least 24 hours plus an insulin drip, because insulin upregulates lipoprotein lipase and accelerates triglyceride clearance, and that mechanism is the reason it works, with a fasting triglyceride rechecked at 4 to 6 weeks, because the acute elevation can be transient. Drug-induced disease is mechanistically mixed, which is the teaching. Azathioprine and 6-mercaptopurine cause an idiosyncratic reaction weeks after starting, with rapid recurrence on re-challenge. Valproate and didanosine act through toxic metabolites, and thiazides and tamoxifen act by raising triglycerides, so the real lesion is the lipid, with a longer list of other implicated agents. And the immune checkpoint inhibitors are worth noting because their pancreatitis is immune-mediated rather than direct Acinar toxicity, so steroids may help there. High calcium is on the workup for unexplained disease because it drives pancreatitis through the same calcium-mediated pathway, from primary hyperparathyroidism, malignancy, sarcoidosis, vitamin D toxicity, or milk alkali syndrome, and correcting the calcium is the only durable treatment. Duct obstruction by tumor is the age-based trap, because pancreatic adenocarcinoma, a neuroendocrine tumor, a mucinous cystic lesion, or an ampullary lesion can present as unexplained pancreatitis, especially over 40, so a first idiopathic episode in that age group needs follow-up cross-sectional imaging, because missing a cancer presenting through obstruction is the failure mode being tested. Autoimmune pancreatitis presents acutely, most often as the duct-centric form in a patient with inflammatory bowel disease, or as the IgG4-related form with painless obstructive jaundice and a sausage-shaped gland, where the whole diagnostic problem is distinguishing it from adenocarcinoma, which is why steroids are held until that's resolved. And hereditary disease is on the workup under 35, with recurrent attacks and a family history, where the dominant gain-of-function trypsinogen mutation has high penetrance and a markedly elevated lifetime adenocarcinoma risk that drives surveillance, so genetic testing is reasonable in that age group because that's where the inherited causes concentrate. Severity stratification runs alongside the cause, and the principle is that organ failure determines mortality, dynamic bedside markers beat static scores, and no single scoring system is enough to triage on its own in the first day. Organ failure is quantified by the modified Marshall score, with a 2 or more in any system defining failure, a systolic under 90 unresponsive to fluids, an oxygenation ratio under 300, or a creatinine in the 1.9 to 3.6 range, and persistence beyond 48 hours is what separates transient failure, which is moderately severe disease, from persistent failure, which is severe disease and carries the mortality. The systemic inflammatory response tracks the same cascade upstream, needing 2 of the 4 signs of abnormal temperature, a heart rate over 90, a fast respiratory rate, or an abnormal white count, And the reason persistent inflammation beyond 48 hours predicts severe disease is that it tells you the cytokine cascade hasn't been contained and organ failure is likely to follow. The static scores each trade-off differently, and that's what's tested. The bedside score, built from a high BUN, altered mental status, systemic inflammation, age over 60, and a pleural effusion, is fast and available at presentation, which is why it fills the first-hour triage slot. The older admission plus 48-hour score is cumbersome because half its variables aren't available when you're actually triaging. The most broadly validated intensive care score needs a blood gas and a dozen physiologic measurements, so it's rarely used at the bedside. And the CT severity index has to wait for the necrosis window before it can score correctly. Running the other way, the harmless pancreatitis screen of no rebound or guarding, normal hematocrit, and normal creatinine identifies patients unlikely to get severe and supports earlier discharge planning. The first-day markers that actually move decisions are the hematocrit and BUN trends, and the reason is mechanistic. Volume depletion from third spacing causes pancreatic hypoperfusion. Hypoperfusion drives more necrosis, so hemoconcentration is a surrogate for the hypoperfusion making the disease worse. A hematocrit over 44 at admission, a hematocrit that fails to fall over the first day, or a rising BUN in the first day, all predict necrosis and higher mortality, so rising values, despite fluids, warrant escalation and ICU consideration even before overt organ failure. ACRP over 150 at 48 hours predicts severe disease but lags too much for admission triage. And a corrected calcium below 8 adds to severity because it reflects fat necrosis saponification. Organ failure ultimately determines mortality, which stays under 2% without organ failure even when necrosis is present and approaches half with persistent multi-organ failure, with infected necrosis after the first week or two adding further risk. And, once again, the enzyme level doesn't track severity, worth restating, because under stem pressure, the temptation is to read a high lipase as a sick patient when the kinetics driving that number are independent of what drives organ failure. That brings the fluid decision, where the rule changed and the change is the teaching. The point of fluids is to reverse the intravascular hypovolemia from third spacing and restore pancreatic perfusion within the early window before the microcirculation collapses and drives more necrosis. Lactated ringers is preferred over normal saline because it lowers the inflammatory markers at 24 hours, proposed to work through calcium-driven trypsin stabilization and by avoiding the hyperchloremic acidosis that chloride-rich saline produces, which itself drives renal vasoconstriction and worsens splanchnic perfusion, and starch-based colloids are not used because they showed no benefit and a trend toward worse organ failure. The rate is where practice changed. The old approach was aggressive crystalloid, a large bolus, then a high maintenance rate, on the idea that more volume reverses third spacing faster, but when that was tested head-to-head against moderate resuscitation, a smaller bolus only if hypovolemic, then a modest maintenance rate, the aggressive arm produced far more fluid overload without improving progression to severe disease, and the trial was stopped early for safety. So the current recommendation is moderate goal-directed lactated ringers at about 1.5 milliliters per kilogram per hour after a 10 milliliter per kilogram bolus in hypovolemic patients, reassessing the hematocrit, BUN, and urine output at 6 to 12 hours with a urine output goal of about half to 1 milliliter per kilogram per hour. The principle inside the new rate is titration to dynamic markers rather than a fixed aggressive volume, so patients with cardiac or renal disease get more conservative dosing because overload risk dominates, and the patient who doesn't respond to moderate resuscitation escalates to ICU care with closer monitoring rather than to a higher fluid rate, because once the microcirculation has collapsed, higher rates just cause overload without reaching the gland. So the first hours run on a few decisions that all reach back to the same mechanism. Trypsin escapes its compartment, calcium stays high, the cytokine cascade fires, fluid leaves the vascular space, and the gland loses perfusion. The 2 of 3 rule diagnoses the syndrome around the failure modes of pain, enzymes, or imaging alone. The cause is worked up during the admission because the trigger reshapes management. Severity is provisional for the first 72 hours because organ failure hasn't declared, which is why hematocrit and BUN trends drive escalation before the Marshall score turns positive. And fluid is moderate goal-directed lactated ringers titrated to those markers, because the trial that asked whether more was better answered no, and stopped early. The next episode picks up in the first days. Early enteral nutrition, usually within 48 hours, because keeping the gut barrier intact prevents the bacterial translocation that drives infected necrosis, ERCP reserved for cholangitis, or persistent obstruction because an empty ERCP only adds risk, and same admission cholecystectomy in mild gallstone disease, because leaving the gallbladder in produces recurrent biliary events at high rates during the usual interval window. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 3 of chapter 25, and I'll see you in the next one.